This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, and thank you for joining us today for our special HealthyU breast cancer webinar series. Today's topic is oncology and the breast cancer treatment plan. My name is Christine Santini. I'm the Director of Marketing Communications at Mather Hospital. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous. I'd like to introduce you to today's presenter, Dr. Yelda Nouri. Dr. Yelda Nouri has been practicing medicine for the past 6 years, providing excellent care to patients across Long Island. She is the lead medical oncologist of the Fortunato Breast Center and sits on the Breast Panel Leadership Committee at Mather Hospital. She continues to devote time and effort to academic practice and is currently affiliated with Stony Brook University Hospital. Dr. Nouri is passionate about community outreach projects that improve outcomes for cancer patients. She is currently seeing patients in multiple locations throughout Suffolk and Nassau counties. Dr. Nouri.
Thank you so much, Christine, for having me today. I'm so honored and I feel so privileged to be allowed to contribute to this amazing health lecture series. So my focus is going to be on breast cancer treatment. As Christine stated, I'm a medical oncologist at New York Cancer and Blood Specialist right here in the community. And that's pretty much about me, which we have already discussed. So just to kind of give you guys a broad overview of what I'll be focusing on, obviously breast cancer is a very broad topic. It's an incredibly exciting, intriguing topic because there are so many new updates. So I'm going to keep my focus really on treatments such as chemotherapy, endocrine therapy. However, I want you guys to all be aware that when you treat breast cancer, surgery is one of the mainstays of therapy along with radiation. And I would like to spend some time to kind of talk about emerging therapies because this is a hot topic and kind of, what's the latest and greatest and how are we fighting the amazing fight against breast cancer. So your breast cancer treatment plan. So first and foremost, I want every woman or man for that matter to be aware that your treatment plan will be guided by certain principles. So your specific type of breast cancer. And when I say specific type of breast cancer, we've all heard about hormone positive breast cancer. We've heard about triple negative breast cancer. We've heard about DCIS, which is considered a stage 0 breast cancer. So again, your treatment will be specifically based on the type of cancer you have. We also, the surgeons, the medical oncologists, the radiation doctors take your age, your health, and comorbidities into consideration. Certainly your personal preferences are extremely, extremely important to us. And, I always say to my patients, you're the captain of the ship and I'm basically your first mate. So I want you to guide the therapy, but I'll help you along the way. And certainly the stage of your breast cancer is very, very important for your treatment plan. And by stage, I mean stage 1, 2, 3, or 4. That's very important. And that's one of the most important things that I say to my patients before they walk out of my office. I want them to have an idea of what their stage is. So briefly on surgery. Your surgical options include a lumpectomy, which can also be called breast conserving therapy, partial mastectomy, and wide excision. Oftentimes when I refer to a partial mastectomy, my patients get nervous. They think I'm talking about removing the entire breast, but partial mastectomy really is equivalent to a lumpectomy. And that is when a tumor and the tumor itself and a small rim of your normal tissue around the tumor is removed and the rest of the breast remains intact. And sometimes when you do a lumpectomy, If your surgeon thinks you need it, we'll also biopsy or evaluate a lymph node close to the tumor. Mastectomy is when the entire breast is removed. So mastectomy is, back when we first developed breast cancer surgery, that was really the only option that women had. As we've become more sophisticated in our surgical options, more and more women have opted to have a lumpectomy or partial mastectomy. So that is another surgical option. Radiation therapy. So what is the goal of radiation therapy, and why do we recommend radiation therapy? Well, oftentimes when a woman has a lumpectomy, we recommend that a course of radiation be administered to the patient after surgery to kill any cancer cells that might be left behind after surgery. Oftentimes these cancer cells are extremely small and cannot be detected by blood work or imaging. So I get asked, well, if everything was taken out, why do I need to have radiation therapy? And what I tell my patients is that, we think that your surgeon did an amazing job at removing as much of the cancer as they possibly could, with the help of our pathologist also examining the specimen. But we want to be extra cautious and eliminate the possibility that anything could be left behind that we cannot see with our eyes. Moving on to, I think, the crux and most important point of my discussion today is something we call systemic therapy. Systemic therapy as a whole is any therapy that your doctor, usually your medical oncologist, will give to you to help prevent the cancer cells from spreading to one part of the body. In our discussion, that would be the breast, to other parts of the body. Systemic therapy, encompasses a broad range of therapy. It includes chemotherapy. It includes hormone therapy, or hormone blockers, which a lot of my patients like to call it, and also includes HER2-directed therapy. So just as some background, chemotherapy, which is traditionally, what everyone thinks of when they think of systemic therapy, can be given intravenously, that means through the vein, or it can be given orally. Systemic therapy that's given after surgery is called adjuvant therapy, and systemic therapy when given before surgery is called neoadjuvant therapy. I only point this out because I think it's important for patients to be familiar with the words adjuvant and neoadjuvant. I always try to, use a terminology that my patients are familiar with. I don't want them to feel like they're, in a lecture hall and, they're trying to figure out what I'm trying to say. So what I often say is, if I'm giving you therapy before surgery, it's called neoadjuvant or preoperative therapy. So I like to, clarify that for my patients. Just as a fact, this is some data that I came across this week. It's well published. It's available on, the American Cancer Society. That in the United States, 276,480 cases of invasive breast cancer were diagnosed in the United States. That's the projected figure for 2020. But that does not include about 46,000 cases of DCIS, or precancerous breast cancer, that's diagnosed, or precancerous cells that are found in the breast. So 276,000, and then also roughly about 50,000 women diagnosed with precancer cells in the breast. So these are, huge figures, and this is why there's so much research and so much dedication towards the field of breast cancer. So the first part of systemic therapy that I want to go into is hormone therapy. So, this slide might seem, pretty sparse, but hormone therapy is actually very complex. And I would say the majority of my time in counseling breast cancer patients is spent on hormone therapy. So the broad overview of hormone therapy, there's a medication called tamoxifen Tamoxifen falls in a class of medication called the SERMs, or selective estrogen receptor modulators. I use tamoxifen, as do a lot of medical oncologists, in young women who are premenopausal. That means that they're still getting their periods. So this is what we often use in young women diagnosed with breast cancer. But tamoxifen does have a place in older women with breast cancer. I use it in patients with something called DCIS, or stage 0 breast cancer, or precancerous cells of the breast. Then there is another class of medication. I would say these are more commonly used in a day-to-day practice. The aromatase inhibitors. And aromatase inhibitors basically target an enzyme that converts hormones into estrogen. So the 3 drugs that are currently on the market that many patients have heard of are Arimidex, letrozole, and aromasin. For the most part, all of these medications are equivalent. Your oncologist may choose to use one over the other based on a certain side effect profile, but generally speaking, these medications are all similar. So one is not better than the other. One might just be better for a particular patient. So don't feel that just because your doctor has you on one and your friend is on another, it doesn't necessarily mean that you're on a bad medication. Another facet of hormone therapy for breast cancer is this concept of called ovarian suppression. So ovarian suppression is only used in a particular patient population, and that includes the premenopausal patient. So this is a woman who is of childbearing age who has not gone through menopause. So these are women who are still getting their periods every month, who are still at an age where they can have children. And if they have a hormone positive breast cancer, oftentimes the oncologist will recommend shots, Lupron. There's also another shot called Zoladex, and these are given monthly, and they're given in the doctor's office. And it's an intramuscular shot, so it does require an office visit. And what this does is, I explain to my patients, it quiets the ovaries. It shuts the ovarian estrogen production down. Alternatively, some women who are diagnosed with hormone-positive breast cancer, who are very young, may even opt to talk to their gynecologist about the possibility of removing their ovaries if that's deemed safe for them. So that's important. Again, this is a collaboration, between your oncologist, your gynecologist. So not one person makes a decision. We all work as a team. So side effects of hormone therapy. This is, basically, my experience with the most common side effects of hormone therapy. The list can go on, but I selected to talk about the things that patients bring to my attention the most. One of those side effects includes hot flashes. In medical terminology, we call these vasomotor symptoms, and these are feelings of intense heat. Oftentimes women have issues with sleeping at night. They're ripping the blankets off of them, and they're making their spouses and loved ones crazy, but that's what a hot flash is. Arthralgias is another word for joint pains. Oftentimes women complain that maybe when they wake up in the morning, they feel achy, but for the most part, with a little bit of exercise and mobility, as the morning goes on, patients start to feel great again. Vaginal dryness is another very real side effect. And, first and foremost, I tell my patients, I say, I want you to feel comfortable talking to me about issues like vaginal dryness. It's a real issue that women have. All women experience it. I don't want, my ladies to feel shy. I want them to feel open, and I have lots and lots of solutions. Every year, as a medical oncologist, I go to, various educational conferences. I try and stay up to date on, the newest trends. And a lot of our discussions at some of these big breast cancer conferences, a lot of time is devoted to vaginal dryness and sexual dysfunction. It's a real issue. There are wonderful vaginal lubricants, vaginal moisturizers, other, modalities to help combat this. I don't want my patients to feel alone or isolated. There are options for you. Moving on, there's fatigue. There's also the possibility of weight gain. It's not explosive weight gain. Sometimes it's a couple of pounds that is difficult to get off, especially in the midsection. Mood lability is a commonly reported side effect. This is usually brought up to me by the spouses. Interestingly enough, like my wife feels very moody, or my sister or my daughter feels moody on these medications. Over time, that does get better, and there are also options to treat that. With the aromatase inhibitors and any estrogen blocker, there is increased risk of cardiovascular disease. So a lot of you, may remember, but a few years ago, we used to think that giving women estrogen after menopause was a good thing because it lowered your risk of a heart attack and cardiovascular disease. But what we ended up finding was that increased the risk of breast cancer, and we didn't like that. So there was a movement that pulled away from using supplemental estrogen in the postmenopausal setting. There's also an increased risk of blood clots. So your doctor will sit down with you and get a thorough history before you start any of these hormone therapies. If you have a history of blood clots, tamoxifen may not be a good choice for you. Also, there's a side effect of endometrial thickening and possible uterine cancer with tamoxifen. That risk is low. In the trials that led to tamoxifen's approval, this risk was very, very low. Probably 1% of patients had this side effect, but it's real, and we have to talk about it and bring it to the forefront of discussion. The next topic that I want to touch on is something called HER2-directed therapy. So HER2-directed therapy really consists of two medications that are commonly used in clinical practice, and what an oncologist will use on a day-to-day basis. The two drugs that we use are called Herceptin, and another one is called Perjeta. Herceptin came to the market quite a few years before Perjeta. These two medications are sometimes given together along with chemotherapy, or Herceptin can be given alone. But typically, if we are using these medications, especially the Perjeta, we combine it with the Herceptin and sometimes a little chemotherapy. These medications are typically given intravenously every 3 weeks. And again, going back to what intravenous or IV means, it means through the vein. So it requires a injection, or some women will have a port put in before they get HER2-directed therapy. In the adjuvant or after surgery setting, we typically give these treatments for a year. And before any woman starts, or man starts, any of these medications, we typically get an echocardiogram. So that's a cardiac scan. And what we do is we look at the ejection fraction of the heart, make sure you have a nice, strong heart. There's no hair loss associated with these two agents, very minimal side effects. Perjeta can cause diarrhea. However, we find this to be more common when it's combined with chemotherapy. So that's something I like for you guys to be aware of. So that's HER2-directed therapy. So this is, I think, something important to touch on, because I get asked this, all the time. What are the factors that affect my prognosis? What is my prognosis? And oftentimes that's a scary, topic to discuss, I think, for the patients and also for the oncologist, because sometimes an oncologist is able to give really, really good news, and sometimes we have to give some bad news. I tell my ladies and men that the factors that can affect your prognosis, probably one of the most important factors includes your lymph node status. So I sit down with my patients after surgery. We look at how many lymph nodes the surgeon removed, how many of them were positive, how many of them were negative. And we basically talk about how many of those lymph nodes were affected with cancer. Tumor size is also extremely important. So what I say to patients is, the larger the tumor, the higher risk of recurrence. So the bigger the cancer is, the worse your overall prognosis is, but that can still be affected by other things. So tumor size is very important. Then another important facet of your pathology, or the cancer once it's removed from your body, is the grade. So tumor grading for breast cancer, we can determine the grade on the biopsy, and we also check the grade when it comes out of your body, when you actually have surgery and your surgeon removes the lump or removes the breast. And tumor grade is important. So tumors are graded grade 1, 2, or 3. And what I always say to my patients is, this is not your stage. Grading is very different. But grading is something we can tell under the microscope. So that's our pathology friends, our colleagues, who tell us the grade of the tumor. The higher the grade, the more likely your cancer is to recur and potentially behave more aggressively. Hormone status. So there are 2 hormone receptors that we check on breast cancer. Every patient with a new breast cancer diagnosis, we check estrogen and progesterone, and then we quantify if it's highly estrogen receptor expressing, and also if it's high or low progesterone receptor expressing. And then we check the HER2 status. Checking the HER2 status is a little bit more complicated. We do a type of test called IHC. That's the first test our pathologist will do. And if your HER2 status comes back something called equivocal, which is very unsatisfying for us, it's also unsatisfying for the patient, because we have to tell them we have to do some additional testing, and that might delay obtaining your HER2 status. But I can assure you that it's for the best. We want to make sure we get an accurate assessment of your HER2 status. And oftentimes, if the HER2 comes back positive by the second test called FISH, it can affect your treatment plan. So it's something very important that we want to make sure we have, especially when we sit down and we start talking about treatment options. Then another thing that can affect your prognosis is something called tumor profiling tests. And these are also called genomic assays. Genomic assays are usually done sometimes before surgery, but oftentimes after surgery. And it's a test that's either ordered by your surgeon or your medical oncologist. And it comes back and it tells your doctors and it tells you, how your cancer is going to behave, let's say, over the next 5 to 10 years. And I will talk a little bit more about tumor profiling a few slides away. And I'll talk to you a little bit about what the names of these tests are called, and what to expect and how long these results take to come back. And then one other thing that can affect a patient's prognosis is something called a Ki-67. And that is a proliferation, and proliferation means growth. It's an antigen, and we look for it in the nuclei or the brains of the cancer cells. And the higher the Ki-67 is, the higher proliferation index that cancer has. And that could mean that the cancer might be more rapidly dividing. And it may mean that down the road has a higher chance, this cancer has a higher chance of recurrence. So those are your factors. So I'm going to spend a few minutes and talk a little bit about tumor profiling, because I think it's nice to be able to know a little bit about the brands and the different tests that are available, that your oncologist will figure out what's right for you. What I can say is I have some amazing, super duper smart, awesome patients who sometimes will come to me and say, Dr. Nori, I really, I love the advice you're giving me, but I want to ask about this test, and I want to know if I'm a candidate for it. And I want you to be that really smart patient who can come to your doctor and ask questions and recommend and advocate for yourself. So the 4 tumor profiling tests that are available, that are recognized by the NCCN and ASCO, one is called the Oncotype DX. The other is called MammaPrint. Another one is called Prosigna, and another one is called Breast Cancer Index. So in my practice, I use Oncotype DX on premenopausal women or postmenopausal women. Prosigna is typically reserved for postmenopausal women, and MammaPrint can also be used in the postmenopausal setting. And these 3 tests are only used for estrogen positive breast cancers and HER2 negative breast cancer. So we don't use them in every cancer type. They're approved, those 3 tests are approved in that setting. And these 3 tests in particular will come back and tell a patient and their doctor whether they could benefit from chemotherapy. So right now in the United States, we use these genomic or tumor profiling tests in stage 1 or stage 2 breast cancer patients. Typically, we like to use them if the lymph nodes are negative, because if your lymph nodes are positive, most likely your doctor might talk to you about chemotherapy. But if your lymph nodes are clean, you could have one of these tests done and you'll get a score. It's almost like a report card. And you know, the ranges are different for each of these tests, but if your score comes back low, there's a very good chance that your doctor is going to recommend that chemotherapy is not going to give you benefit and that you don't need chemotherapy. On the other hand, some of these tests can come back and they can show that there is a benefit for chemotherapy, and it'll actually give you percentages on what your chance of recurrence is in the future, and it'll help guide decisions on what type of chemotherapy your doctor may choose for you. The breast cancer index is, I think, a really cool test, and a lot of my patients and I have been talking about it, and we have decided to order it. So breast cancer index is a test I use for women who have been on these hormone blocker treatments like Arimidex or tamoxifen, and around year 4 or 5, when they're getting ready to stop, we can order this test, and it'll help us determine if that patient is someone that should be on the hormone blocking treatment for 7 to 10 years, or whether 5 years is adequate for them. So this is a really nice test, especially for women who may be having side effects related to those medications and who would like to come off if it's safe. So again, these are some great tests that I want you guys to be aware of, and that's tumor profiling. Some other medications that we discuss in the treatment of breast cancer include bone density medications. So why would we be so vigilant about your bones? You know, we're treating your breast cancer. Why do we care so much about your bones? Well, interestingly enough, a lot of those medications, the aromatase inhibitors, and sometimes medications that we use for ovarian suppression like Lupron, they can make your bones brittle. They can make the bones weaker. And if you're going to be on these medications for several years, I say to my patients, well, we want to make sure going into this, your bones are as strong as possible. So I typically recommend a bone density in a postmenopausal woman every 2 years. And if a woman sits in front of me and they have a new breast cancer diagnosis and they haven't had a bone density in 10 years, I'll usually get an updated bone density test. And sometimes your gynecologist will do it in the office for you, which is amazing. So I'll give you a prescription, and you can either go to Mather, you can go to a local imaging facility, you can go to your gynecologist and get an updated bone density. If you have osteopenia or osteoporosis, sometimes your oncologist will recommend that you go on a bone strengthening medication. At New York Cancer and Blood, we use denosumab or Prolia. This is a rank ligand inhibitor, and it's given subcutaneously like a flu shot, so it's not painful, or very painful, I should say. It's convenient. It's given every 6 months. Or we could use a medication called Zometa, which is a bisphosphonate, and that's given intravenously or through your vein every 6 months for a few years. So sometimes we'll give these medications for 2 years, some for 3. And what we have discovered, especially with drugs like Zometa and denosumab or Prolia, that these drugs may lower the risk of recurrence in women with early stage breast cancer. So it not only strengthens your bones, but it reduces the chance that your cancer could come back. So this is a really, I think, exciting part of breast cancer treatment, and really shows you that medical oncologists will treat you as a whole, not just your breast cancer, but we're interested in your, sexual health, your bone health. We're generally very interested in your overall well-being. So an exciting area that I'd like to, touch on are emerging areas in the therapy of breast cancer. So I'm going to flesh out this slide a lot. I kept it as simple as possible because this is a very, very, complex topic, but I think it's worth touching on because, believe it or not, my patients are pretty smart, and they come to me and they ask me amazing questions, and they ask me about new therapies and new drugs and new trials. And I find that very encouraging because that means, women have access to more education. They're spending time, they're researching breast cancer, and they're researching therapy. So capecitabine is a very, interesting drug. It's an oral chemotherapy agent, so it's taken by mouth. It does not require IV access. And there was a trial a few years ago that was published in the New England Journal of Medicine called the CREATE-X trial. And what it showed is that women with certain types of breast cancer, especially triple negative, who had gotten chemo before surgery and may have still had some cancer left behind after chemo and surgery, could get a medication called capecitabine. And they would take that for about 6 months, roughly, and that would reduce the chance that their cancer would come back in the future. What I find very appealing about capecitabine is that my patients can take it at home. There's no hair loss. They can call me about any side effects, but generally speaking, it's well tolerated, and the dose can be adjusted to be tailored to the patient. So that's really, really exciting. So a great medication, and I think very reasonable to use, especially in a woman with triple negative breast cancer. The next emerging, really exciting therapy for breast cancer is something called antibody drug conjugates. Initially, these antibody drug conjugates, which paired chemotherapy along with a antibody that helped deliver the chemotherapy to the cancer cell, initially we were using it in patients with stage 4 disease. That's where cancer has gone from the breast and spread to other parts of the body. But now more and more we're realizing how good these medications are because they take the chemotherapy and they pair it with the antibody, and it brings it to the cancer cell. And we're starting to use it even in earlier stage breast cancer. So there was a trial that was very, very important that was published last year, and it changed the course of action for many oncologists. It was called the Catherine trial. And what it showed is that for women who had cancer left behind, who were HER2 positive after chemotherapy and maybe Herceptin and Perjeta, after surgery, if they still had some cancer cells left in the breast, we could give them an antibody drug conjugate called Kadcyla, or TDM1, and it combines chemotherapy along with Herceptin, and we give that, for the remainder of the year. So that's usually about 11 treatments. And this drug causes no hair loss. It's very effective, and we also found that the patients with HER2 positive disease who got this medication did much better in the long run. Then there's a class of medications called the CDK4/6 inhibitors. So these are medications like Ibrance, Kisqali, Verzenio. I can't open up a People magazine without seeing a ad for Ibrance. So I know a lot of women have come across this medication. I've had women who've come in with articles and they say to me, is this a drug that I would be a candidate for? So we have traditionally used the CDK4/6 inhibitors since they came to the market a few years ago in patients with stage 4 breast cancer. Now, more and more, there's new data emerging that we can use these medications in patients with high-risk breast cancer. So patients who have surgery who are not stage 4 but have a lot of lymph nodes that are positive for cancer cells. There was a trial that was recently published called the Monarch E trial. And that was very exciting for us. So we're starting to incorporate the use of these medications earlier. Another class of medications that we use in patients with stage 4 disease is a class called PIK3 inhibitors. And this is especially for patients who have a particular mutation called a PIK3CA mutation. And if you have this mutation, that means you're a candidate for this drug called Piqray. And it's another option for you if you have stage 4 cancer. Another modality for treatment is something called immunotherapy. We've used a lot of immunotherapy in the last few years in lung cancer. And finally, the breast cancer oncologists get to use these amazing medications. And a lot of us thought we were a little late to the game. But finally, Tecentriq, which is an immunotherapy, was approved for the treatment of triple-negative breast cancer. That's stage 4. And we are also getting emerging data that an immunotherapy called Keytruda, which is another one you see all over TV and all over the ads, that we can start using this in patients before surgery for triple-negative breast cancer. And then there's a type of medication called a tyrosine kinase inhibitor. And there's one that we use in breast cancer that is very exciting called neratinib. And it's an oral medication. And again, no hair loss with that, some diarrhea as one of the side effects. And this is an option for patients who have very high risk HER2 positive breast cancer, who maybe have lots of lymph nodes involved and maybe need a little bit more therapy after they finish chemo and Herceptin. And their oncologist thinks that maybe they should go on this pill, and we usually use it for a year. So that's also another wonderful, wonderful option for oncologists. So all of these are just wonderful strategies, all these wonderful things we have in our armamentarium to treat the patient and to have breast cancer patients live longer, live cancer-free, and it's a really, really exciting time. So I'm glad we got to mention these today. So, one of the last topics I'd like to, touch on is something that's very real. It's tough. It's a tough thing to talk about. It's a concept called recurrence. That means when cancer comes back, what do I do? What happens? So I'd like to kind of differentiate recurrence into, two major categories, because recurrence is different for every patient. And the first, section I'd like to talk about is local recurrence. So local recurrence can happen after a lumpectomy, and it can also happen after a mastectomy. So what do we do if cancer comes back after a lumpectomy? Well, we can, incorporate your surgeon back into the game plan. We can consider doing a mastectomy if the cancer came back in the breast. We can offer you radiation therapy if it was not given to you originally for whatever reason. And also, you'd be a candidate for chemotherapy, hormone therapy, and HER2 therapy, depending on what receptors your recurrence expresses. If you have a recurrence after mastectomy, there are still options for you. If you have a chest wall recurrence, if you have a recurrence in your armpit or your axilla, we can offer you surgery, radiation, and systemic treatment, which would include all the other things we talked about before, like hormone therapy, chemotherapy, HER2-directed therapy. And oftentimes when you develop a recurrence, your oncologist may recommend to you that we do scans on the entire body to rule out the possibility that there's cancer anywhere else. So don't be frightened if that's what the oncologist recommends. It's just know that it's what we typically recommend for all women who have had a recurrence. And then the question of metastatic disease. So metastatic disease is our most feared complication of cancer. It usually means that the cancer has spread to a different spot, so it's gone to somewhere else in the body. If your original cancer was in the breast and it goes to the lung or the liver or the bones, that means it's gone from one place to another, so that's a distant recurrence. The symptoms are very, very broad. So when I say fatigue, shortness of breath, bone pain, weight loss, seizures, jaundice, it's very variable. I always say to my patients, if you think about feeling like your cancer came back just because you were feeling fatigued, you might feel that several times a month. I say to my patients, if something doesn't feel right and you know yourself better than anybody, you need to contact me immediately and we'll work that up. So when patients come to me and something's not feeling right, we start off with blood work, a good physical examination, and then we recommend possibly some imaging. And if something seems suspicious, then that leads us to do further workup and possibly even a biopsy. So I just want everyone to be aware of that. Great. I'm going to leave it there because I'd love to, keep some time open and answer potentially any questions. I put my email up there. I also put my Instagram because I have a lot of personal interest in bettering the lives of women with breast cancer. So a lot of times I share with my patients my tips, tricks on how to feel great, how to look good, how to maintain self-esteem during their cancer treatments. And, that's probably one of the coolest things about my job is that I get to share experience and make the lives of my breast cancer patients better. So I'd love it if anyone wanted to contact me. I truly mean that. And if it takes me a day or so to get back to you, it's only because I'm probably busy seeing patients, but I will definitely touch base with you.
Thank you, Dr. Nuri, for your extremely informative presentation. If anyone has any questions, you may enter them in the Q&A feature on the bottom of your screen. Just give them another minute. If anyone's interested in asking any questions, please feel free to enter them, and your questions are anonymous.
And like I said, if you think of something, I know I'm giving you guys a lot to kind of think about. Feel free to, email me. I know I gave a very dense. Okay, so Christine, is it okay if I read this question out anonymously and answer it if that's possible?
Yep, that's perfectly fine.
Sure. So really nice question. When you have an overactive thyroid, is that a sign of possible cancer in the breast? That's a really, really good question. And truthfully, I will say that, anytime there's something maybe out of the ordinary, especially with your, thyroid, I think that warrants an evaluation. Having an overactive thyroid is not necessarily a sign of cancer in the breast, but I think if you have an overactive thyroid, that requires, I think, a good evaluation by your primary care physician, possibly even seeing an endocrinologist. And if you are not up to date on your breast imaging, I think it's important to also address that when you get an evaluation for your overactive thyroid. It's a great, great question. Another great question. So how quickly should you start treatment after diagnosis? There have been many, many studies that have looked into this exact factor. Unfortunately, when women have surgery, sometimes there are unforeseen delays, infection, postoperative complications. So typically what I say to a woman is ideally within 3 months of surgery, you should have a game plan. You should have sat down with your medical oncologist. If you're supposed to have radiation, if you're supposed to have chemotherapy, you really want to get that plan in place after surgery. So I typically see my patients 2 or 3 weeks after surgery. We sit down, look at the pathology, and then, move forward. We typically don't recommend radiation therapy for until about a month after surgery. So if you're very lucky and we sit down together and we say you don't need chemo, then we'll go ahead and proceed with radiation therapy, within about a month, just to allow your body to heal. And then also we incorporate the opinion of our surgeon. It's not always our decision. We get clearance from your surgeon, and we work together to do that. The next question I got was, what is considered a high Ki-67 score? So typically, when we get a report from the pathologist, anywhere between 1% to 20% is considered low. Really moderate is 20% or above. When you start getting a number in the 50s, 60s, 70s, that's considered a high Ki-67 score. Another question is, what blood components show breast cancer? So that's kind of a tough question, because most of us know that breast cancer there's not a good test for to look for breast cancer. So there's no easy test to perform to screen you for blood cancer. There is no screening test for breast cancer in the blood. What I say is, if you have a diagnosis of breast cancer, you've had imaging, a biopsy, then it's reasonable to talk to your medical oncologist if they think that maybe you should have something called tumor markers in the blood. Following tumor markers in the blood, some oncologists don't feel it's necessary. Some do, but I think once you have a diagnosis of breast cancer, it's reasonable to ask your oncologist if they can do a baseline, and if it's normal, you can, just monitor it. But there's no good blood test that shows breast cancer. It's all through, clinical approach, recognizing your breasts, examining your breasts, being up to date on your imaging, and just being diligent about your care.
Does anybody have any further questions?
Those are really, really great questions. And just to kind of throw out one other thing I get asked a lot about are supplements. So I know there are ladies out there who are like, what supplement should I be taking? I typically say, keep it simple, have a great healthy diet. I usually plug most of my patients in with a nutritionist. If you're eating a nice varied diet, you really don't need a ton of supplements. I swear by vitamin D. I think it's important for your bone health. I recommend D3 2000 IUs daily. For some of my women who may be experiencing some hair thinning, I'm a big advocate of biotin. I also, just think, keeping your skin moist and using products that don't have a lot of perfumes and coloring. I think all of that is good for you and safe. So I spend a lot of time talking to my patients kind of about things after that help them feel good. So I think that's an important part of your care as well. So one of the questions, what diet would you recommend for a woman on hormone blocking medication to help with weight gain? Great question. This is a tough question. These are those extra few pounds that a lot of women complain about, especially on the hormone blocking treatments. The big diet that I typically recommend is like a Mediterranean, lots of fish, staying as plant-based as you can, lots of cardiovascular activity, and then also weightlifting. I think a lot of women are afraid of weightlifting, but it actually does help burn fat more efficiently. And then it's not so much a diet, because I'm really not into diets. I think counting your macros. So that's something you can, sit down with a nutritionist, where you basically calculate your protein requirements, calculate how many net carbs you should be having, and really trying to make sure you're getting the proper amount of nutrients based on your body mass index. So if I've ever tried to, eat healthier, I've always gone to macro, where I'm calculating how many fats, how many grams of protein I should be having. So I think that's not so much a diet, but it's a lifestyle recommendation. And eating every few hours, I think, keeps the metabolism up. And then there's a question about deodorant. I got to be honest with you. I think, the data is really not that convincing that a certain type of deodorant causes breast cancer. I think that's kind of a myth, but I will say that a lot of my patients, I've tried it because I've recommended it to my patients. Native deodorant, it's very natural. They sell it at Target now. It used to be available only online, but a lot of my patients have been liking Native. I've personally used it because I don't like to recommend anything unless I've used it myself, and they love it. So I'd say if you want to go all natural, stick with Tom's of Maine or Native. And I also just this month for our practice newsletter created a little a column, and I'm going to kind of be addressing these health and beauty issues with breast cancer patients. And my first topic was actually nail care. It's a very common question I get asked. What should I do with my nails? And I usually recommend keeping them short, clean, moisturizing, moisture gloves. So I'm going to be focusing a lot on that in some upcoming articles and stuff, because that's something that's really important to my ladies, and I want to make sure it's addressed.
Well, if that's it for the questions, I just want to thank you again, Dr. Nouri. If we didn't get to your question, as you can see, Dr. Nouri's email is displayed on the screen. Otherwise, if you'd like to email us at matherhospital@northwell.edu, we will reach out to Dr. Nouri and get anything answered that you wish, or email her directly, as she indicated. This presentation was recorded, and it will be available on our website at matherhospital.org/HealthyU, as in the letter U for university, matherhospital.org/HealthyU. And once you exit the webinar, you'll see a link to complete a survey. If you could please complete the brief survey, your feedback is extremely important to us. Thank you again, Dr. Nouri, for your time and sharing this very important information with us.
Awesome. Hopefully see you guys in person next year. Take care.
Thank you.
Bye.
Bye.